In 2002, millions of women abruptly stopped hormone therapy. The Women's Health Initiative trial had just reported that the treatment increased the risk of heart attacks and strokes. This panic was triggered by a specific oral medication, a pill combining conjugated equine estrogens with a synthetic progestin. Because this trial enrolled women who were often a decade or more past the start of menopause, its findings were applied to the entire category of hormone therapy, linking the treatment to cardiovascular harm. For the next 20 years, medical practice treated all hormone therapy as a heart risk, based almost entirely on the effects of that single oral pill given late in the menopausal transition. Newer data, known as the timing hypothesis, shows that starting therapy near the onset of menopause is actually associated with lower cardiovascular risk and reduced mortality. In trials of early initiators, those taking oral estrogen saw rates of heart failure and myocardial infarction drop by roughly half compared to those receiving no treatment. But a conflict remained. While the oral estrogen helped protect the arteries, it simultaneously doubled the risk of dangerous venous blood clots. Measured, this creates a physiological paradox, a medication that protects the heart's arterial supply while threatening to obstruct its veins. The hormone's effect depends on the physical journey it takes into the human body. A traditional pill enters the digestive tract, absorbs through the stomach, and travels directly through the portal vein into the liver. This triggers first-pass metabolism. The liver reacts to the concentrated oral estrogen by pumping out an excess of coagulation factors. As these factors enter the venous system, they create a clotting penalty, increasing the risk of deep vein thrombosis and pulmonary embolism. The estrogen eventually reaches the heart to provide its biological benefit, but only after provoking this hepatic reaction. The oral route forces the body to endure a dangerous clotting side effect to deliver a cardiovascular benefit. Transdermal patches solve this by delivering bioidentical 17-beta estradiol through the skin, paired with micronized progesterone. This route allows the hormone to absorb directly into the bloodstream, bypassing the stomach and the liver entirely. By avoiding the liver's first-pass reaction, blood coagulation remains neutral, and the clotting penalty is eliminated. This bioidentical estrogen reaches the vascular system and binds to receptors in the arteries, without the presence of excess clotting factors. At these receptors, the estrogen improves nitric oxide signaling and preserves endothelial function, keeping the arteries flexible and healthy. Changing the entry point removes the cardiovascular danger, while preserving the hormone's biological benefits to the heart. If oral pills yielded a net heart benefit while actively causing clots, then a transdermal route, which delivers the same hormone without that clotting activation, points towards a highly favorable cardiovascular profile. Observational studies consistently show that transdermal estradiol and micronized progesterone carry neutral risks for stroke and blood clots. Despite this anatomical evidence, the patch is not officially prescribed to prevent heart disease. A sound biological mechanism is a signal, but modern cardiology requires a specific standard of proof. Clinical proof in cardiovascular prevention is measured against a very high bar. Drugs like statins have been proven to reduce actual heart attacks and deaths through massive, dedicated clinical trials. This is the missing evidence for transdermal hormone therapy. Medical science has not yet completed a long-term cardiovascular outcome trial for the patch. Following the initial 2002 findings, the institutional appetite for funding large, expensive hormone trials virtually disappeared. The lack of definitive proof isn't a result of a failed trial, but because the definitive trial has not been run. For early menopausal women, transdermal estradiol is the safest regimen for symptom relief, carrying a favorable cardiovascular profile, even if it is currently classified as a biological signal rather than a proven prevention.